bile acid on ductal function.
Okay, thank you very much, Moran.
Yeah, I mean, we have to move on to the next one because of the lack of time, but we will work on it. Thank you very much.
Our next speaker is Adrienn Kéri from the National Pancreatic Institute.
Thank you and welcome everybody. In the following few minutes, please let me introduce the early results from the Hungarian cystic fibrosis related pancreatic disorder registry data. As we have heard, go forward.
Tell us by heart.
By heart. So as we have heard before, life expectancy of patients with cystic fibrosis
It's getting more. Yes.
is increased in the past decades thanks to new therapeutic options such as Orkambi.
Right.
Yes, so let's start again. So welcome everybody. In the following few minutes, please let me introduce the early results from the Hungarian cystic fibrosis related pancreatic disorder registry data. So as I have mentioned, the life expectancy of patients with cystic fibrosis increased in the past decades thanks to new therapeutic options. Therefore, complications that need time to evolve, such as osteoporosis or cystic fibrosis related diabetes, has come into light. As we have heard before, the etiology of cystic fibrosis related diabetes is complex and multifactorial. But we have to highlight that the diagnosis of cystic fibrosis related diabetes is associated with worse lung function and increased mortality, and it could be avoided by early recognition and treatment. As we can see, the pathogenesis of cystic fibrosis related diabetes carries both the pattern of type 1 diabetes as insulin deficiency due to beta cell loss or beta cell dysfunction, but also the characteristics of type 2 diabetes as insulin resistance due to chronic baseline inflammation that flares during acute pulmonary exacerbations. By the age of 40, approximately half of the patients has cystic fibrosis-related diabetes. But we have to think about diabetes as the end stage of a progressive disease. Just like a type 2 diabetes, before diabetes, there are pre-diabetic conditions, such as impaired glucose tolerance. Basic scientific research suggests that this pre-diabetic condition starts at early ages in cystic fibrosis. However, characteristics and dynamics of the progression in the abnormal glucose tolerance status is still unclear. And the oral glucose tolerance test, which is the gold standard method for diagnosing abnormal glucose tolerance, is only recommended from the age of 10 according to the guidelines. The 2-hour oral glucose tolerance test with only 2 time points, one at 0 minutes and one at 2 hours, has been separated from the oral glucose tolerant cutoffs intent to detect type 2 diabetes and its pre-diabetic conditions related to obesity, and maybe not optimal for detecting cystic fibrosis relevant clinical decline. The 2-hour oral glucose tolerance test with interim time points at 30 minutes or 60 minutes or 90 minutes may be better suited for cystic fibrosis-related abnormal glucose tolerance, as studies prove that the elevation of the 1-hour glucose levels are associated with clinical decline. However, and anyhow, the oral glucose tolerance test still has its limits because not all the age can drink the sugar liquid which is needed for the oral glucose tolerance test. The aim of the cystic fibrosis-related pancreatic disorder registry is to assess the prevalence of abnormal glucose tolerance in our registry populations. So in children with cystic fibrosis, especially under the age of 10. As you can see, 91 patients are currently involved in the registry. From those 91 patients, we have analyzed the baseline data of those 79 patients who were able to undergo oral glucose tolerance tests whom were previously diagnosed with diabetes. The oral glucose tolerance test was performed for 3 hours with measurements in every 30 minutes. The children drank 1.75 gram per kilogram sugar, maximum 75 gram per sugar before the oral glucose tolerance test. The long-term goal of this registry, with yearly follow-up visits, yearly sampling, and annually reevaluating the abnormal glucose tolerance status, is to earn knowledge about the characteristics and dynamics of the progression in the glucose tolerance status. As you can see, approximately half of the patient has 2-year follow-up visits, and approximately a quarter of the patient have 1-year follow-up visits. With the annually sampled biosamples, we will have the chance to find biomarkers as early predictors of abnormal glucose tolerance. By analyzing the baseline data of these 79 patients, we can see that the percentage of abnormal glucose tolerance is approximately 30 to 40% in every age group, including indeterminate glycemia, impaired glucose tolerance, and cystic fibrosis-related diabetes. The proportion is even that high under the age of 7, in which age group the oral glucose tolerance test is non-mandatory according to the guidelines. If we visualize and compare the glucose concentration curves during the oral glucose tolerance test with 2 time points and the oral glucose tolerance test with interim time points, the difference is striking. As you can see, with the oral glucose tolerance test with 2 time points, only the impaired glucose tolerant group would be diagnosed. However, as you can see, during the oral glucose tolerance test with interim time points, those with indeterminate glycemia have spent their time, half of their time, about 10 millimole per liter glucose concentration. This high level surely suggests an abnormal glucose metabolism. And so does the reactive hypoglycemia after 2 hours in the indeterminate glycemia group and in the impaired glucose tolerant group. In cystic fibrosis, the earliest insulin secretory defect is the loss of the first phase insulin secretion. The reactive hypoglycemia after 2 hours is likely related to that delayed in first phase insulin secretion, followed by a robust but poorly timed second phase insulin secretion. As we can see during the oral glucose tolerance test in the indeterminate glycemia group and in the impaired glucose tolerant group. Let's have another look to the diagram I showed you before, but as you can see, the proportions have changed because those patients whom had 2 or more glucose concentration higher than 11 during the oral glucose tolerance test in the interim time points were further investigated at our endocrinology ward. The 12 times a day glucose monitoring was carried out, and we consulted with the endocrinological specialist. Thanks to that examination, further 4 children who had the diagnosis of diabetes and started insulin treatment before any complication. And as you can see on the diagram, 2 of them were diagnosed under the age of 7. The early recognition and treatment of the abnormal glucose tolerance is crucial, as an uncontrolled glycemic status leads to rapid clinical decline. Here you can see the table with the 4 glucose tolerance status group: the normal glucose tolerance, the indeterminate glycemia, the impaired glucose tolerance, and the cystic fibrosis related diabetes. And you can see the baseline characteristics of the patient. As you can see, the worse, the more progradiated the abnormal glucose tolerance status is, the worse the lung function and the bacterial colonization. As we can see, looking at the forced expiratory volume results, comparing cystic fibrosis related diabetes measurements or to normal glucose tolerance. Or we can see a tendency in the bacterial colonization of Pseudomonas aeruginosa. To summarize our results, we can see that in our population, abnormal glucose tolerance is highly prevalent with 41%. 17% of the patients have cystic fibrosis related diabetes. 22% of the abnormal glucose tolerance was diagnosed under the age of 7. 2 had cystic fibrosis related diabetes. I have to highlight that this age group is not mandatory screened according to the guidelines. If we had used only oral glucose tolerance tests with 2 time points, 34% of the abnormal glucose tolerance cases would have been missed. If we had used oral glucose tolerance tests with interim time points without any further investigation at the endocrinological ward and without an endocrinology specialist, 31% of the cystic fibrosis related diabetes cases would have been missed. In conclusion, we need better awareness for screening abnormal glucose tolerance in cystic fibrosis, especially under the age of 10. It's time to reconsider the current guidelines and change screening strategy. And there's a burning desire to develop a patient-friendly screening method which is suitable for diagnosing even toddlers who cannot drink the sugar liquid which is needed for oral glucose tolerance test. Thank you for your attention.
Very much for the nice presentation. So you suggest to reconsider the guidelines.
Yes.
Is it published data you mentioned?
It's not published yet because they are just preliminary data. As I mentioned, we have follow-up with it, and we consider to publish the data with the follow-up with its result as well.
Yes, but do it quick, as the guideline will be revised to the Hungary list. Sure.
Yeah, I also have a question. It's very similar to me like the pineapple data. If we look at every patient who has abdominal pain at the emergency, you can measure the amylase and the lipase concentration at ultrasonography. You can detect much more acute pancreatitis. It's here if you measure for every children, every CF children, at the very beginning, everything that you can detect more. Based on your very preliminary data, can you see any kind of clinical signs or any kind of clinical data which could be associated with the bound glucose abnormality? Because somehow we also, like in every screening program, like in cancer and in other programs, we should find a high-risk group which could have been tested in the early phase.
Yes, there are some clinical features that can be associated with abnormal glucose tolerance, but the earliest abnormal glucose tolerance status is very asymptomatic. In the more progradiated abnormal glucose tolerance status, such as impaired glucose tolerance or cystic fibrosis related diabetes, the frequency of acute exacerbations or the decline in the pulmonary function can be prognostic factors. But in the earliest cases, they are very asymptomatic.
It's very interesting that the most severe patients won't have diabetes as they won't reach the, if I remember correctly, some 50% of the patients will be diabetic by the age of 40.
Yes.
But the most severe patients won't reach the age of 40. But what you show, the data, who have impaired glucose tolerance were in fact the most severe group.
Can I make a comment on that? Yeah, go
Yes.
ahead.
So the most severe patients who cannot reach the age 50, they will develop cystic fibrosis-related diabetes early on in life. So that's what we see. So they develop the cystic fibrosis-related diabetes at 20 years, for example. So they are affected by this complication.
So the most severe diseases that we see, we always say it depends on the lung phenotype. So when it comes to the pancreatic phenotype, the less severe mutations are the ones that cause the issues with acute pancreatitis, and these are the ones that have some CFTR mutations that go on to have early signs of diabetes, even after a single attack. And that's a form, you can say, of maybe CFRD-related diabetes in a pancreatitis patient. But a couple of points for you. I totally agree with you. When you publish the data, you want to update your guidelines. From what we know from the evidence and some of the evidence that you showed, that we screen children earlier, and we have to. But some of the ideas that you could do, definitely do the interim tests. If you're going through the oral glucose tolerance test, you don't want to just get the 0 and the 2 hour, because most of them normalize at the 2 hour. But as you said, the money is in the test in between, and those are the responses of the insulin to the glucose surge. And over time, you learn your population this way. We do in the children who cannot do glucose itself because it's nasty.
Yeah.
We actually converted totally to what we call a mixed meal tolerance test, which physiologically resembles more what your pancreas has to do to produce insulin in response to a meal. And what we do, we have a formula, a Boost essential formula that has a certain carbohydrate content, protein, and fat. And then we normalize it, or we say the doses per body weight.
Thank you for your comments.
I'm happy to share the protocols as well.
It's fantastic.
It is, yeah, it's a liquid formula. It's a certain type. So between us, the University of Minnesota, because we see a lot of children with CF, and I believe the nationwide group in Columbus, they do the same thing. So we do it for exocrine pancreatitis patients, but also for CF patients. And actually in my pancreatitis patients, I do it at least once, and then yearly some diabetes testing. But those are the earliest signs of abnormal endocrine function in them.
Thank you for the useful comments. And to add actually in plus information, we tend to do a trial with continuous glucose monitoring with a normal meal routine and see the glucose concentrations during the day. Avoid the 12-time measurements at a day.
More questions, comments? Thank you very much again.